we're going to start out here. My name's Tracy Moody Cessna. I'm a physical therapist. I work at the TQL Stadium downtown. We have a clinic that's open to the public for patients. I am the site supervisor at that office. I am board certified in orthopedics as well in physical therapy. I'm a certified running coach. I also have a certification in vestibular and concussions. I use a little bit more of the concussion side of that than the vestibular. And then trained in dry needling as well. And then I was a Division II collegiate runner. Besides that, as you'll see from my pictures, I like to sweat and then dress up in really fancy clothes. I'm active in our professional organization, which is the APTA, and I'm fortunate enough to be an elected delegate to our House of Delegates. I've been doing this for, I tried to do the math every time and I always screw up, 15 years.
Hi, and I'm Tiffany Godlove, and I work at our Mercy 5 Mile just down the street. I've been with Mercy for 12 years now, and I specialize in sports medicine, dry needling, manual therapy, and I also, in the fall, spend my time at McNick High School helping on the sidelines.
Hi, my name is Maria Felblinger. I am also a physical therapist at the 5 Mile location down the street. I am an RRCA certified running coach along with Tracy, so we just have a little bit more credential to help formulate training plans for runners and walkers. And I also do our running and video gait analysis at our clinic. I have 15 years of experience as a physical therapist, and I believe I've run 4 marathons and about 8 half marathons, but I'm currently not running. I'm more on the walking side of things, so I understand both avenues.
All right, so as I said, welcome. I just want to kind of see who we're talking to tonight and what you guys' background is. How many walkers do we have? Okay. Runners. Okay, I was going to say, I say some shirts that look like you might be runners. Anybody who's planning on starting a running routine? Anybody who's planning on starting or modifying their walking routine, changing things up? Okay. Okay. So it's an intimate setting. So if you have questions, we'll pause at the end for questions, but feel free to kind of let us know if you have anything going on, and we'll try to interact a little bit and keep you rolling. So the reason we wanted to kind of do this talk is because injury rate is super prevalent in runners and walkers. This study that was done in 2018 reviewed common injuries for each body part, but basically they found that 66% of runners out of 252 that they studied sustained an overuse injury within 1 year. Out of that, 56% were injured more than once. So, we see a lot of repeat customers. And I tell people all the time, my job as a physical therapist is to make you not need me. So, we want you to be independent. We want you to get back to what you want to do and want you to learn how to safely manage your health conditions. Out of this study, they also found that the knee is the most injured site, followed closely by the foot. The big thing I like to stress that we don't always talk about is the last bullet point. Of note, injured runners report a significantly worse mental health, and that includes more negative emotions. How many of you run or walk with someone else? Yeah, there's a social aspect to it, right? So it's really hard when you see your friends posting or texting or saying, "Hey, we had a great walk," and you're like, "I'm sitting on the couch, I see my knee," So there's that component as well. And I feel like a lot of us too, we identify as a runner or a walker. We wear clothes that say the Heart Mini or Fleet Feet Running Club or Tri-State Running or whatever it might be. So that's part of our identity. It's almost like when you pull that shirt out of the closet and you're not running or walking, you're like, this kind of sucks. And you have that FOMO when you see everybody out in the street on a nice day. So that's really important to think about. And when we see people in the clinic, we try to address those kinds of things as well. We're not mental health providers at all, but I think it's really important that we keep that in the back of our mind. This study just came out very recently. I can't remember, probably within the last couple of years. So if I told you all that you're going to pick a sport and this is the injury rate of that sport, you may not pick it, right? So this is where we start. We're all healthy and we look good. And then over the course of running 1,000 kilometers is 2,000 kilometers, which is 621 miles to about 1,242 miles. The injury rate just keeps dropping. And the attrition rate just keeps dropping. So I just like this diagram. I think it's really blunt and in your face of this is how many people get injured over the course of time of running that amount. They've used GPS tracking in this study, used Garmin information on this. But like, the big thing, like I said, I wanted to take home from this is that a lot of us are probably likely to get injured at some point in time. So I want to talk a little bit about some of the common injuries that runners and walkers end up confronting. Anterior knee pain, which we call runner's knee, pain that you have going up and down stairs, going up and down hills, usually down. Achilles tendinopathies, really common, especially as we age. We lose some elasticity in our connective tissue. Hip bursitis, IT band syndrome, stress fractures, bone stress injuries, and plantar fasciitis. So those are some of the big things. We're not going to go over into all the stuff. I'm not going to read to you like the clinical prediction guidelines for how to recover from an anterior knee pain. But I think what is the big thing to take home from this slide is that it's really important to strengthen these muscle groups that we use, but maybe we use them a little differently when we run or we walk. So I say that because I have this conversation with my patients all the time. Okay, you run. Do you cross train? Well, I bike. Okay. I walk or I swim. I'm like, okay, what do we swim? We swim freestyle. So we're still only going this way, right? When we only go this way all the time, our muscles that go this way forget what to do. But it's really important that our muscles that help us to go sideways are strong. So if everyone can just stand up right now, we're going to try something. If you feel safe to try this, try it. If not, please just stay sitting. Or you can try it with a hand on the chair in front of you. I want you to try to stand on one leg. Yep, or you can stand with one foot in front of the other. Do we feel those muscles working a little bit? If it's easy for you, you can close your eyes. If it's good for you, stay right there. But I just want you to feel like, hey, when we stand on one leg, we really have to work that hip muscle to help stabilize everything. Our ankles have to work. Our feet and knees have to work. You can have a seat. This is really important because when we run or we walk, when we run, we're simply doing this jump and then this jump, right? So we have to keep our hips level, and our hips need to be super strong for that. But when we run, we don't work them the same as if we play tennis or if we play basketball or if we swim like a butterfly or something like that. So I tell my patients it's really important to try to do something sideways. You know, whether you play a pickup game of basketball with your kids or you start, you do a little pickleball, or as simple as it might be of like, let's do some band walks and let's walk sideways, or let's do some clamshells. If we're suffering some heel pain or some calf tightness, some things we might try to do to help prevent that is we might do some calf stretching with the leg straight and the leg bent. We might do a big toe stretch, those kinds of things. So we won't go into all the details there, but it's really important to tell my runners, my walkers, like twice a week, it's good to at least do something sideways or do some strengthening that's different than how we load our bodies when we run, because we still need those muscles. We just use them a little differently.
Okay, so I'm going to go into a little bit of kind of our total body assessment for runners, but this also would include a walker. So the biggest part of the assessment would actually be the stuff we're not seeing and talking to you about the history, or what we call our subjective. So we want to know, what is your sport? Are you a walker or a runner? How long have you been participating? What's your injury pattern? Or what are you coming in to see us for? What are your concerns? And then we also look at, do you have a new onset of pain? Is this a chronic onset of pain? What are you training for? So are you trying to walk a mile 3 times a week? Are you trying to just walk, you're going from a 5K to a half marathon distance? Are you trying to increase your training volume? So we kind of look at the pattern of, your practice before we get into what's actually bringing you in and bothering you. We also like to look at your injury history specifically. So is this a recurrent injury? Are you having pain at the beginning of a walk or a run that gets better as you warm up? Are you having pain that worsens the longer you go or the longer the distance you go? Is your pain just after activity? Are you really sore in the mornings? Is it better by the afternoon? So that kind of lets us know what we might be dealing with before we even physically look at the body. We also just kind of ask about pain. Are you having it at rest? Are you having it just with activity? Are you using ice, heat, medications, that kind of stuff? We also ask about your shoes. So what type of shoes are you in? Are you in a neutral shoe? Are you in a stability shoe? Do you wear an orthotic? Is it an off-the-shelf insert or is it a custom orthotic? Have you changed shoes recently? And we like to look at old shoes. So oftentimes we'll have clients bring in their old shoes and their new shoes, and we look at the wear patterns on the shoes. And we'll get into that a little bit more later on today. So after we get a good history, then we want to actually examine how you're moving. So we do both a static, or meaning not moving exam, and then also a movement exam. We're specifically looking at your strength, your flexibility, and your mobility. And by that, mobility of your joints specifically, not just how flexible your muscles are. Okay. We specifically look at the trunk, the hips, the pelvis, the knees, the foot, the ankle. Okay. We also look at the shoulders, the neck, because that affects our walking and running form as well, but more specifically from the trunk down. And when we're screening, when we're screening for strength, we're primarily looking at the core and the glutes, but also quads, hamstrings, calf, foot, and ankle. When we're looking at flexibility, we're really looking at the muscles that cross two joints, specifically the hips and the knees. So we think of our quadriceps, our hip flexors, our hamstrings, our calves. Those are all two joint muscles, and so they're going to affect us differently than if we had a static rest position. In joint mobility, we're looking at the mobility of our trunk, our spine, our hips, and our foot and ankle predominantly. So then we'll also get into some gait analysis, and I have some pictures of this coming forward. But other things we look at as a whole, we're often asking about people's cross training. So are they biking? Are they swimming? Are they walking? Are they playing pickleball? And then what are they trying to train for? What's their schedule? So what is their pace? How many days a week are they training? What's their training plan? So we're trying to get an idea of like the surfaces somebody might train on. Are they on trails? Are they on hard road? Are they on track for walking and running? We also look at like estimated mileage per week. We look at training volume, or what we call session training. We'll get into that a little bit as well. And we're also asking about height and weight. If for females, do they have a normal menstrual cycle? If they're a little bit younger. If they're perimenopausal or menopausal, are they dealing with osteoporosis or osteopenia for bone density and weight-bearing activity? And then we're also going to look at somebody's static standing posture, and then we're going to look at their mobility when we actually watch them start to move. So in static standing, we're looking at posture, foot position. We're looking at how they squat, how they lunge, how they balance on one foot. And once we start to have them move, then we're starting to look at joint angles and muscle strength and form. And we have some pictures to show that. So what we look for is not just what kind of shoe does somebody need, or do they need an insert or not. We're really looking at the full picture, what we call the whole closed chain. When our feet are planted, we're looking from the ground up, the whole body. So see what deviations we might notice. Is there pain in certain parts of somebody's gait cycle that we can kind of pick up where they might be having issues. And then any of the things that we notice, it can help us formulate a training plan. It can help us give corrective exercises. Are we noticing something that might necessitate a referral to a physician? Like, are they dealing with a stress fracture? We need to send them for an x-ray. So this kind of lets us know where do we need to start them. And the whole purpose of this would be to allow people to stay active. So we don't want to have to shut people down if they're injured, but we want to allow them to try to stay active within their parameters of what they're dealing with. We also see people who are not injured at all. They just want to be more efficient and get better and have better form, or try to change their training plan and they're not sure where to start. Do you have the clicker?
No, we do, but it doesn't work.
Okay, so some differences for walking and running. So our stance phase means when our foot is in contact with the ground. Our swing phase means when our leg is pulling through. So differences for walking and running, we are in contact with the ground with 2 feet on the ground for 60% of our cycle. And we're in that swing phase when our feet are off the ground for only 40%. So we have 2 periods where we have more support. And as we figured out with Tracy's exercise, it's easier to balance on 2 feet than it is on 1. So as soon as we get into running, our stance and our swing flips. So we're in a higher percentage in that swing phase, or what we call a double float, when both feet are not in contact with the ground versus when we're in contact with the ground. And when we're in contact with the ground on that 1 foot, it takes a lot more neuromuscular control to keep our pelvis level, to keep our hip, knee, foot aligned underneath our center of gravity. We also see a bigger demand for joint excursion or joint range of motion when we're in that single leg stance phase. So we tend to see a little bit higher proportion of injury when we get into running, but we still see a lot of injuries in walkers as well. We are typically looking at the increased demand for strength for a runner as compared to a walker with some of this presentation. Okay.
Next slide.
Any questions on the swing and the stance phase? That probably makes sense just by looking at the pictures there. Okay, so for a video gait analysis, we use just very simple software. So we just have a regular treadmill, an iPad or a tablet, and then we use a couple different analysis programs. There's one called Huddle, Coach's Eye, Dartfish. They're apps that we could all download on our phone and also use just for regular, free use to videotape ourselves on the treadmill. We place markers on the different Bonelian marks. So on Tiffany, so from a side view, we would put a marker on her side of her shoulder, sometimes the side of the elbow and the side of the wrist if we need to, or if they have like a long sleeve shirt on or it's harder to see those landmarks. We put one on the outer hip, the outer knee, the outer ankle, and sometimes the outer part of the metatarsal here on the fifth ray. So we're looking at those just to kind of show up more obviously for us on the treadmill so that we can also draw angles among the joints to try to get our norms to compare things to. And we usually do on both sides. Yep. And then we also look from the back view. So if somebody, barefoot running was a really big thing a little bit ago, it kind of goes in waves, but sometimes we'll also put some markers on the foot to bisect the heel if we need to look at somebody's foot position, when they're not an issue. A lot of shoes have markers on them, just like the colors and the patterns. So sometimes we need some markers on the shoe to get a little bit better measurements on that as well. But the apps have the ability to zoom in, so we can usually find what we need, even if we don't have the markers perfectly. Okay, so typically what we'll do is we'll have our runner or a walker do a warm-up. So if you're a walker, we might have you just walk around the clinic before you get onto the treadmill. If you're a runner, we'll have you usually walk and then jog on the treadmill and then get to your comfortable running pace before we take any video. We want you to be warm and try to best capture your mobility in that still frame. A lot of my people who come in for this haven't ever been on a treadmill. They're only an outdoor person. So that's the one wild card. We don't run as ideally when we're on a treadmill. We all walk and run a little bit better when we're just out. So that's the user error problem of the treadmill. Sometimes we're not as comfortable with being on the treadmill. And so that maybe alters our gait and our ability to kind of stay in that little bit of frame of the treadmill. So what we'll do is we'll take video from the back, the front, and the right and the left sides. And then again, we have the ability to zoom in a little bit more on specific body parts, especially the feet helps us to get a little bit closer view. We don't need much video at all. We really get about 30 seconds or so in each frame because what we're really doing is slowing it down to get into the specific phases of somebody's gait cycle. And we use those still frames to draw our angles and to kind of compare. And you'll see an example of that in a few. The other things we look at while you're running is we measure your cadence, which is how many steps or foot strikes you're getting per minute. And we kind of have our norms for a walker and a runner, what our steps per minute should be. And then we take these, all these screenshots and we look at the joint angles. So we're measuring the trunk angle, we're measuring your pelvis, your hip, your knee, the foot, ankle pronation, supination. Again, sometimes we'll also look at the shoulders, the neck position, the elbow if there's something funky going on up above. And we look at different cycles of gait. So everyone stand up just to wake you up again. So when we would take a stride, right when my first foot contacts, that's called our initial contact or our initial stance. So right when I go to accept my weight onto that foot. When I accept my weight over and I'm ready to shift, that's called our mid stance. So when my center of gravity is over that stance leg. And then when I go to take my other leg through, that's called my swing phase. When I go to put my other foot down again, I go into terminal stance or terminal toe off on the one leg and then my initial contact again. So we're really breaking it into initial contact, mid stance, and then terminal stance. Those are kind of our main phases. But then we're also looking at that swing phase because we can see some patterns in those as well. I know that's a lot of information. So what questions do you guys have so far just on that before I show you some pictures of our gait analysis? Anyone have any immediate questions? Other things we might listen for are people's landing. So think of a runner or a walker who's really, really heavy and you hear them coming versus someone who walks or runs by you and they're so silent. So sometimes we can gather a lot about someone's striking, if they're a heel striker versus a midfoot striker versus a toe lander when they're walking or running. Yes? Yeah, so we'll talk about it a little bit in some of the pictures coming up. However, we try to land as close to under our center of gravity as possible. My best analogy is if you have a dog on a leash and you're trying to pull that dog and they're kind of putting the brakes on and not going. So if we land really far in front of our center of gravity, we're essentially braking ourselves from going forward. So if I am a lot more of a heel striker, if I strike way in front of my base of support or in front of my center of gravity, I tend to have more ground reaction forces. I'm loading my joints a little bit less efficiently than if I land under my center of gravity. And I'll show you an example on the next picture, but it's not that all of us should be midfoot strikers or toe strikers, right? But we see some injury patterns, especially like stress reaction type stuff, anterior knee pain, some of these common injuries when we see people get outside of their center of gravity for landing. We also have some exercises and some simple strategies that we can give people to help them land a little bit more under their center of gravity. And a couple really quick little tips that, literally in one session, you can learn how to improve that a little bit for yourself. Any other questions?
So were you saying that the
Not always. So sometimes it's truly like also a vertical displacement, right? Because you can see some really springy runners or walkers. But we typically will hear somebody be a little bit quieter when they're landing underneath their center of gravity. Not always, but kind of if we had to generalize.
We're also listening left and right. Like if we can tell if someone has an
Yeah,
injury
so
on
like,
one side, they might go, yeah, exactly. They're going to get off one leg a little quicker. Or like if they have like a shin weakness, they might like hit and then
their
like
foot might
slap
slap.
and the other side. So sometimes when we're doing like a gait analysis or we have someone on the treadmill, like we'll just close our eyes because we're just listening to hear.
Mm-hmm.
So sometimes it's a right and a left difference too.
Yeah, and those are things you can't pick up on video always, so just listening sometimes is very helpful. Any other questions on that before I show some pictures?
on an earlier chart, that injury chart,
Yeah.
that cumulative your lifetime?
That's
miles?
over the miles that they studied. So over like,
Miles they studied.
which was 1K, I think it's 2K, which is 600 to 1,200 miles. So they stopped the study at that point, but it's a very big study. You ready for the next slide?
Yeah. Oh, and there's one other point. So our cadence, and this is more geared towards runners because there's a little bit more research about ideal cadences, and we have the Olympics going on right now, so you can all count how many steps per second if you can count how fast their legs are moving. But ideal cadence for a runner is approximately 170 to 180 steps per minute. Are you a better runner if you run at 180 to 200 than if you're a 150 runner? Not necessarily. We're not trying to change people's form per se. We're trying to help people get a little bit more efficient and maybe reduce some injury patterns. So some of the best runners in the world have funky form. They have, their leg kicks out, their arms kick out. You look at them, they should not look like a good runner and should not look fast, but they're crazy speedy. So it's not always about perfect form making somebody a good athlete or less likely to be injured. Okay. All right. Moving on.
Next slide.
Okay, so this was a woman from probably, I don't know, when was our last clinic? 3 years ago. She agreed to be in some presentations that I had given for some other things. So she actually goes to the health club. You might see her, and hopefully her form looks a little better now. But this first picture, so this is just an example of looking at her from the left side, that very first picture there. And there's a lot of angles on there, but this person was very interested in learning the angles at every single joint. So they wanted to know what their elbow, their trunk, their neck, kind of as runners, some of us are a little bit more type A. We want to know all the details. So I was going through every single body part with her to try to figure out chronic injury for her. She had probably 10 to 15 years of hip pain. Okay, she sat for her job, but then she was a marathoner. And so she was doing high training volume, but then she sat all day for work. So she was having a lot of recurrent hip injuries, a lot of SI and back pain, a lot of bursitis. You name it, she had it. and really needed some footwork, some knee work, some hip work, and then ultimately a lot of core work. So she came into me not for one specific injury, but she just saying, why do I keep having these, patterns that are kind of moving up and down the body, and never really being able to figure them out or actually be able to reach her training goals. She was trying to run marathons and she just could never stay healthy enough to actually get to that. This is her initial contact. So her initial contact, if we would draw a plumb line right down the center of her body here, this would be where her center of gravity lands. It's approximately just in front of our pelvis. So she is a heel striker. She is landing in front of that center of gravity. And that was kind of her initial. And with different frames, you might see a little variety when I take these screenshots. What I do is just go through and try to find the best picture that would represent my ability to draw those angles for somebody. And the exact same thing would apply with a walker. Okay. So we would do that from the other side as well. Look at all the angles, calculate them out for somebody if they needed to, or try to look at injury patterns. Also, what part of their cycle is she hurting in? Does she hurt when she strikes her foot? Does she hurt when she's on that leg? Does she hurt as her leg is pulling through? So all that information she gave me in her history helps me look at this and then try to correlate those findings. So this would be a back view. So we're looking in this. So we're looking at her chicken wings, first of all. Okay, she had a lot of lateral movement. And then we're looking at how much her pelvis drops. It's normal for us to have our pelvis drop when we walk and when we run. That's normal mechanics. If it's excessive or it doesn't drop enough, we see problems and patterns up and down the chain. Can anyone guess which leg gave her more trouble just by those two little shots up there? Her left versus her right leg? Any ideas? Vote for right. Who votes right? Who votes left? Right, left? Yeah. Yeah, you can't lose. So she did have bilateral symptoms, so both sides, but her right side bothered her more. And if you look at her knee angle, okay, can anyone see how her knee angle looks a little bit more inward, and her pelvis and her hips are down and her arms kind of splay out from her sides a little bit? So little things like that you can't catch when you're going really fast with someone running. What we see is sometimes somebody just has a little bit of a trunk lean when they run. So you might see someone who gets a little bit more lateral movement instead of straight and efficient. Or you might see their arms get going, or their arms cross their body. Or we see the knees knocking together. Or do you kick yourself every time when you're swinging? You're like, why do I kick my shin every time I pull through when I'm walking and running, but I don't on the other side? So little things like that, it's helpful to slow down and get some angles and say, where does this person fall? What's the norm? Where should they be? What range should they be? And are they meeting that range, or is there something we can do exercise-wise to get them a little bit more efficient? This is not a picture sample of her feet because I didn't have a very good clear one to blow up on the screen for you guys. This is somebody else's. So we'll usually take a back view and we'll look at the stance phase, but also the swing phase. So this would be the right leg stance and then the left leg stance. So you guys may have heard the terms pronation and supination. Those are both normal parts of our walking. If we're excessive or not enough of both, we can have issues. So it's not bad to pronate. It's not bad to supinate. If we're outside of those ranges, we can see issues. So we zoom in and then we can measure a little bit. And this is where sometimes somebody has new shoes or somebody has really old shoes or they wear an orthotic or they're looking about a custom versus an off-the-shelf orthotic. We can make some recommendations based on the angles we're seeing. So pronation is normal when we strike. If you guys want to stand up really fast. One more wake up. So when our foot strikes, so when we get that initial contact, we're actually slightly supinated or slightly on the outside of our heel. When we accept our weight, we begin to accept and then we start to pronate. Okay, that's how our body accepts our weight. And then when we go to start toe off and push off, we re-supinate at the end before we pull through. Our big toe also has a big component of that. Our big toe needs to be flexible and it has to have a little bit of a rigidity to it in order for us to push off. So that's where if we see people too much pronation, they pronate too late, they pronate too early, they stay supinated, they don't have good toe mobility, we start to see problems travel up the chain. So that's when we can start to have your plantar fasciitis, your Achilles tendonitis, shin splints, stress fractures, knee alignment, hip drop. We see it all the way up the chain just from the foot and the ankle. Okay. Any questions on those little brief screenshots? Yes.
Really fix that.
So we're not always trying to fully fix. We're trying to figure out where is their injury, where is their pain, or is it a matter of efficiency? So if we can get someone a little bit more towards the norms, if we can get them not dropping their pelvis as much by giving them hip strength exercise, do we need an off-the-shelf orthotic or stability shoe to help them not overpronate so they don't have that shin splint? So sometimes little tweaks or just little noticing factors can really make a big difference in someone's training and efficiency. The other part is we're not always trying to correct everything. So when we do these exams, sometimes we make you feel horrible about yourself, and then we slow you down on video and show you your form, and you're like, is that me walking and running? But it might be 2 or 3 things that if we address, we can really make a huge difference and get you to being able to walk or run without pain or reach your goals. And it's not very many big changes. It might be 1 or 2 little things that make all the difference. Okay, so we make you feel bad and then we kind of build you back up. That's the plan. So, any other questions on that? Yes.
Do you have any about
Hammer toe? What do you want to know? We do have a lot of things we can do for hammer toe. Maybe that's something I can address with you a little individually at the end to give you more specifics. But so what he means by hammer toe is sometimes you see people kind of have like clawing of the toes, and the alignment of their metatarsal joint has started to change. So instead of, we have different joints at the toe. So we can maybe give you some pointers on that more specifically to answer your question. But yeah, hammer toe can be a painful condition when you're walking and running because sometimes we don't have the full mobility of those joints, or the tendons have shortened, and we see some differences in the foot mechanics because of having to accommodate for that. So any other specific questions? But the important things to know, I didn't put all the joint angles on here to bore you, but usually, I'll go through and measure the hip, measure the knee in every phase if people want to know it, and kind of see where people stack up if they need help with form or help finding their injury patterns. Yes? Good question. So sometimes we will see somebody, let's say you're injured and you come in specifically for this. Sometimes we'll say, you know what, we actually need some physical therapy, a couple sessions to make sure your hip bursitis goes away and we actually get you feeling better. And usually I'll videotape you as you're healing and hopefully doing exercises, and then recheck you and say, okay, is your pelvis not dropping now? What's your leg alignment look like? Do you feel better? Because it doesn't matter what you look like on the picture. It really matters how you feel, right? But sometimes somebody doesn't have an injury, or they're not actually, they just want to know what they look like and what their form is like and how efficient they are. They might not need to come in, months later to reassess. They might just come in for that corrective exercise session. We'll talk a little bit more how that's structured and the options, but they might come in and see what they look like, learn a few exercises that might help tidy things up, and then go on their way and not need us. But there's always the ability, if something worsens, that can become a doctor's visit or physical therapy. Or do they just need some pointers and they're curious about their form? Do they need some efficiency tips or a training plan, or kind of a cross-training plan to help them reach their goals? Anything else to add, guys, on that?
No, I think the only thing I would add is everything depends on someone's history too. So the reason they're doing this depends on what's going on in their life. And then like Maria kind of alluded to, there's a couple different routes. We do a cash-based service for this, or we can do it through PT, like she was saying, if you have someone who's injured and you're checking them throughout the process. So it covers basically all your bases.
And the last little bit of information I was going to go over is just a little bit more detail about orthotics. So not everyone needs an orthotic. Most things we can manage with keeping good wear patterns on our shoes and keeping our shoes new enough. Years ago, we probably all got 1 or 2 or 5 or 10 years out of our shoes. The newer foam, the newer technology, a little bit more cushion, a little bit more support. However, it hardens over time. So that foam, the rubber tends to harden and it gets a little bit more rigid. So a lot of the shoe companies, some of the presentations we've gone to, have used to say, you get 500 miles on your shoes. Now they're saying more like 350 is what. And I was just at Buckeye Running Company up the street, and they told me, yeah, we recommend replace every 350. It's good for their business, right? But it also keeps us coming back in and trying to keep our shoes a little bit fresher, which might also help prevent some injury. So we kind of need to know our foot type. Do we have a rigid foot? Do we have a flexible foot? Are we pretty neutral? Do we supinate? Do we pronate? Are we within the norms? Are we excessive? So sometimes we need a neutral shoe. Sometimes we need what's called a stability shoe that has a little bit more added support. Sometimes we need a shoe that is more cushion, okay? So we have the different shoe types when we go to a shoe store, and they're usually grouped by the type, and we can kind of also learn the stack of the shoe, how big the heel drop is. So those are all factors. We talked a little bit about that wear pattern. We supinate to pronate, we resupinate. So we should see a little bit of an S-shaped pattern on the bottom of people's shoes. So something you can do at home tonight is you can take all of your shoes, set them down on a flat surface on a counter, left and right, and look at them when you're not standing in them. Does one of your shoes lean over off the edge? Does one of your shoes roll over onto the inside of the toe? Just kind of look at the wear patterns and then flip them over. Look at where your rubber has rubbed off. Do you have a nice S-shaped pattern on the bottom of your shoe? Or is all your wear on the inside or the outside or all on the toe? Is all your wear on the heel? Is it more on that midfoot? That tells you a lot about your pattern without having to ever do a video analysis. So we also keep track of the mileage. So we can see problems at any of those phases of gait. We can see it at the heel strike, the mid stance, the toe off. So if we're seeing that and we can't address it with a stability shoe or a neutral shoe, we have the option of putting just an off-the-shelf insert. You guys have heard of Dr. Scholl's. There's Super Feet, there's Power Step, Curex. If you go to any of the local running companies, they'll have multiple brands of orthotics. And some of those orthotics are 3/4 length. They go to the kind of the toe area, the ball of the foot, and some of them are full length. They go all the way to the toe. And a lot of them have a little bit of cushioning built in, or they might be slimmer to fit into dress shoes. So most places will carry a lot of options. And those are all just prefabricated, kind of one size doesn't always fit anyone perfectly. But most of the time, if we need a little bit of correction, we can get by with a shoe change or maybe a shoe plus an off-the-shelf insert, okay? And many of us have worn off-the-shelf inserts just for comfort, right? To have a little bit of arch support in our shoes. If we're seeing big differences left and right foot, or if we're seeing kind of asymmetry, or maybe we had a foot fracture and we have a steel plate and I need to accommodate that big toe. Maybe I do need a little bit more support that an off-the-shelf or a shoe can't fix. So I have the option to do a custom or a semi-custom insert. There's a brand called BioCorrect, which is like a semi-custom. It gives you a kind of a prefabricated platform that we can add some posting to. We can add some metatarsal pads. We can add a little bit of a shank to accommodate somebody's foot type. And then we can go all the way out to a custom insert. So we can mold you either in a box or with a scanner to get a 3D model of the foot if somebody would need very specific for a foot injury or a foot or ankle injury. Some people need something on one foot and not on the other. So that's where sometimes you need a custom if you can't accommodate both feet evenly, because both feet are not always the same. Okay. So we have a couple examples of a custom insert just to pass around.
You'll see one's for supination, one's for pronation, so you can look at the difference, like what you might get in that, and just pass them around so you guys can feel them, press on them.
And with any custom insert, there's so many options to make them, different densities, different types of foam. Does somebody stand in a factory all day versus are they just using it only for their recreation? So there's lots of options when you get into those custom options. Questions on that? Does anyone wear custom inserts? Gotcha. Does anyone wear off-the-shelf inserts like a Dr. Scholl's or a Super Feet or Power Step? Has anyone gone to some of the local running stores to get like their foot scanned and use some of the basic 3D scanners? So it's always a good place to start if you don't know your foot type and just say, look, I'm looking for my next pair of shoes. What do I need? Just a very basic start is sometimes helpful enough to feel good on your new training program. So this would be what we offer. A store would not offer a gait analysis. They might watch the foot type. So most stores will have like neutral shoes, shoes for supinators, shoes for overpronators. They'll have things organized by like the heel stacks or the millimeters. Sometimes, the employees are trained, to watch people walk, watch people stand, and kind of get a baseline read. I don't want to speak for everyone because you might have a physical therapist working at a shoe or running store who knows a little bit more, or you might have someone who really doesn't have training in that, but is trained to look if people roll out or they stand and roll in when they walk. So you might get the full gamut. However, they do offer the footwear types that if we would send you, we can give you like a prescription. Say, hey, I'd like you to go to the running store and look for a neutral shoe. And it might be, you try New Balance, Adidas, Asics. You go try all the brands, but we want you in a neutral shoe. And we kind of give you just that loose guideline. And then you go see what feels good to you. You go see how it fits you, how the width is, how you like the lacing and the fabric. So sometimes we're just giving a little bit of a guidance of, hey, we want you in a stability shoe, or we want you in a neutral shoe, and then you're going to put your super feet on top of that. Okay, so sometimes it's just a general guideline, and then sometimes we usually always try shoes and then off-the-shelf insert before anything custom, just because of the expense. But sometimes, if someone had a bad foot fracture or ankle fracture, we know that we might need something a little bit more custom for that person. And if that's the case, they're usually in a neutral shoe, and we put that on top. Good question. Depends on the material. So some of them, literally, I think you could drive a truck over and they would still last. They're so hard. I have a pair of those from back in the day. And then you have some that might get, depends on the volume of your training. If you wear them just for your training versus do you wear them to work and walk in daily, you might get a couple years out of them. But I would say on average 2 to 3 years, or an upward from that. Is that your experience as well?
Yeah, I would say it also depends on the company that makes them, because I know some companies will recommend, after X amount of a time frame that you had it checked again just to make sure that, because the orthotics that they make now custom are way lighter than the orthotics they made 5 to 10 years ago.
They tend to, the padding of them, the foam kind of starts to deteriorate a little bit faster. It's kind of cork materials, very lightweight. So they're definitely more comfortable maybe than they used to be years ago. However, they might not last as long.
Just like shoes, right? They used to last longer, and now they're lighter and faster, right? So anything else you want to say?
Nope. Any other questions on orthotics? You can, yeah.
Okay, so this slide is nice. It kind of recaps like what are some nice pearls to take home with you, just like nice factoids, but also simple things that you can implement, tonight or tomorrow. Gait can be influenced from the spine down and the foot up. So when we do an assessment, we're looking at your back, we're looking at your hips, we're also looking at your feet. So keep those things in mind as you train. There's a study that came out that said increasing your cadence by 1 step per minute helps decrease bone stress injury by 5%. That's a huge thing. And I like to stress that people don't change your cadence all of a sudden, because everyone's like, oh, great. If I do 180 steps a minute, I'll be great. You'll be in tomorrow to see us for your Achilles. So it has to be a gradual process. But we know that even 1 step per minute can make a significant change. The research shows that if we increase your cadence by 5 to 10%, we can significantly decrease the pain that you're having in your anterior knee, for example. So when I do it with my patients, and you guys can speak up if you do it differently, I usually use a metronome and I do it a gradual training. I don't say, okay, we went from 160 steps and we're going to go up to 165. I'm not expecting you to do every run at that pace or that cadence. And we use treadmills too, because everyone wants to think, well, if I just run faster, that's not the case. You have to keep the pace the same, right? So if you run a 10-minute pace, continue running a 10-minute pace, we have to take more steps per minute. So
yeah. 1, 2, 3, 4, 5.
Every contact. Yeah. A lot of your phones, even if you carry it in your pocket when you walk, will give you your cadence. Watches, a lot of times the smartwatches now give you cadence. but cadence should not be increased by more than 10% to preserve running economy. Going back to that fact of like, you can't just keep increasing it and expect that it's just going to keep getting better. Just like running 5 miles this week is not better if you run 50 miles next week. We have to find a happy middle ground. Hip abduction strength, super important. We've talked about that a lot tonight. If we increase that, so they've done a lot of studies. Nike's done some research with this. The top level athletes are putting out 95%, 90%, if I remember right, of their body weight by lifting out. I was like, do you expect me to do that? I asked in the course, they're like, if we do, like, if you can go more than 35% of your body weight, you're going to have a significant decrease in injury rates. It's a good way to decrease your injury rate. Plyometric training is super important, especially for our runners. It has been shown to decrease the risk of bone stress injury and promote bone quality. That seems counterintuitive. If I have a stress fracture, I don't think I should go jump on my foot, right? But we do know that your bone becomes deaf to the signal of the to recreate more bone after a while. So this morning, you all got up, put on a shirt, went to work, whatever you did for the day. Do you remember that you have a shirt on you right now until I asked you about it? You probably forgot, unless you have like a tag that's irritating you or something. You probably just, your body gets used to stimulus all the time. The same thing happens with your bone. So after about 20 reps, some studies say 100 reps, your bone's like, boom, over it, I don't hear it anymore. So research is starting to say, we need to try to give a pause in that break. So like, say you go run at 5 in the morning, and then you want to try to help, we're trying to get back from a bone stress injury, you should try to apply a little bit more stress on those bones after about 4 hours. It takes about a 4-hour time frame. So say maybe I finish at 6, I want to go at 10, and maybe I just do some light jumping. So jump rope, you can do a box fall off, whatever that might be. We know that that helps to stimulate that bone growth. But again, if you have a current stress fracture, don't do this. But we know that applying those stresses, given some time for those bone cells to wake back up again, it's been helpful to help increase the strength of the bone. So plyometric training does reduce the risk on bone stress injury and increases bone quality. I'm not saying go out and run 500 miles next week. Yeah. So we know a lot of times, we see this a lot in our aging females, right? We need to increase the stress on the bones so that they get stronger. There's been a lot of research recently, especially with our perimenopausal, menopausal women to start lifting weights. You know, a lot of us, my generation is okay with getting into the weight room, right? But a lot of times that's not the same for other generations. But we do know that it's good to apply some stress. It doesn't mean you're necessarily the right candidate to jump, but maybe we start to load, and maybe we start to get into the gym and we put a little bit more stress on our bones, but it's within a tolerance. And we're going to talk about that.
Yeah, kind of a follow-up on that. I'm just thinking of my wife. She's a walker, but she's dealing with osteoporosis diagnosis. So do you guys help with that kind of training?
I mean, it's definitely within our scope to practice it. I would say personally, I don't see someone come in with just a strict diagnosis of osteoporosis, but it definitely is within our scope to. The big thing I would say is start talking with the physician and talk about what are other ways that I can apply a stress. And then, a local PT could help with that. And you want to find a program that's right for her, right? You don't want to just, she sounds like she's walking, which is good.
She's walking. She's starting to lift weights. There's something called a lift more study she's heard about, and she's trying to get help. It's like none of the trainers here.
Yeah.
Here.
Yeah, I was gonna say, yeah.
Do you work here in the?
Yes, I do. I run the My FedEx program, which
We're going to talk about that too. Yeah. So there are definitely like lots of options. It's the key is finding the right dosage that's appropriate. So we're going to talk about dosage a little bit in this slide. We talk a lot about volume when it comes to running and walking and strengthening. And we used to look a lot at volume being how many miles a week do you run? And then we only want to increase that by 10 to 20 to 30%, depending on what study you read. But really, we're starting to look more at what's volume in terms of duration, intensity, and frequency. So we're going to look at this two ways. We're going to make it, one way is going to be super simple for everyone to understand. The other way is going to be for the someone who's super excited about numbers and really wants to like look at this. Or maybe you're struggling with injuries and you're like, I really need to look at this a little bit deeper. So this is an RPE chart. Are you guys familiar with heart rate zones? Okay. So it correlates with your heart rate zones. So 5, 4, 3, 2, 1. And the examples are on there. Like, Kent said it really nice in his talk yesterday. I'm not going to be able to steal it nicely, but a 1 is, if you're saying you're running or walking at a 1, you need to get off the couch and move, because a 1 is just sitting there. But these have examples of like what that exercise level might be, and it correlates to like a heart rate monitor. So if you're using that, you can use that as well. So a safe progression, like we talked about, volume is 10 to 20% per week. So a lot of times we get people come in and they're like, oh, I just increased my mileage by like 10%, but now I'm hurt. Okay, well, what else did you do? Well, my wife took a spin class, so I did that with her. And then my son wanted to play soccer, so I did that with him. And then I did hill repeats, and I did a tempo run, and then I did a 20-mile long run. And I'm like, what'd you do the week before? I ran 20 miles. And you're like, okay. That we talk more about that acute on chronic workload. So we know what your base load is in terms of that chronic workload, and then we're looking at what that acute workload is compared. There are ratios and math behind this if we want to get into the weeds. But the big thing I tell patients is, if we talk about the FIT principle, F-I-T-T, frequency, intensity, time, and type. For everyone who's in my clinic, this is the thing I talk about when we start sending you home. Change one variable a week. Don't do more than one. If we say, all right, I walk 20 miles a week, that's my baseline, but now I want to start doing some pickups. So I want to walk faster from this telephone pole to that telephone pole. Okay, great. That's all you're doing. Don't start adding a yoga class, and don't start adding more time on your walk, that kind of thing. So changing one variable a week is the safest way to go. So this is an example of how you might apply volume to your training, or you might use this equation. So it's volume is minutes times RPE. You could use that chart or heart rate monitor times runs per week. So if someone comes in, they run 30 minutes, they say their RPE is a 5, and then they also ran 3 times that week. That's 450 session RPEs. So you would take that, and you could take that and times 10 to 20% for the next week is what you could increase that by. You want to go more than that. So like I said, you can get a little bit mathematical and geeky and type A, like a lot of us are, or you can just be like, hey, I'm gonna start playing pickleball, but I'm just gonna do it for like 15 minutes once a week.
All right, so I'm just going to kind of recap all the resources that we've talked about and what we have to offer you through Mercy. So we have the certified running coaches with Tracy and Maria, our local ones. We have orthopedic specialists, sports specialists, which is myself. Most of our clinicians all around the city are all manually trained, which just means we're able to do mobilization, soft tissue work, do manipulations if it's appropriate on you. And then we really try to each year get in the literature, the research, what's most current practices to make sure we're up to date with what is the best way to either prevent or get you back from an injury. And so some of those things that we practice are dry needling, which is basically using a needle to get into a trigger point to release tension. It can help with pain, also just chemically reset things. Yes? It's much deeper. So we're going like almost into the bone, into deep trigger points. So some places like as far as massage therapy or those kind of things where we can't get into that, this can take it into that trigger point on a much deeper level to reset things. Yeah, so somebody, you say if you're a runner or walker and having Achilles pain, then we might do dry needling to your calf to release some of that tension to help with mobility or pain. And then we also do blood flow restriction, which is basically you need a tourniquet around, most of the time we use it for the lower leg, so up around your thigh, and it's occluding your blood flow, oxygen, and we have found that that actually helps promote muscle growth. So say if you are recovering from an injury or stress fracture, you're not able to get that load or do your weightlifting, we can utilize this to help keep you strong during that process. And then we have an Ultra G treadmill, which I'll talk about a little bit more in depth here in a second. And then if you are at kind of higher levels, we have a human performance assessment. And that includes looking at body composition, looking at VO2 max, getting on a bike. It looks at like a two-dimensional video of your jumping, your landing mechanics, balance. So that's kind of a little bit more to really help your performance. And then as they mentioned, we're able to do the custom orthotics. So kind of wherever you're at, we're willing to meet you there. And then, which we'll kind of talk with Emily a little bit, but no matter what stage you're at, we really pride ourselves on communicating, whether you need to see a physician to start with, you have an injury, and then we feel like therapy is appropriate. And then if we want to take you to the next step, to get you back into your performance, we can pass you off to Emily with the HealthPlex program. So no matter where you're at, we really try to make sure it's a smooth process for you and that we're all communicating through those steps. And as I mentioned, one of the things that most of our clinics have is this Ultra-G treadmill. And so it's an unweighted technology where we can offload your body weight as down to 20%, all the way back up to full 100% body weight. And so it's a really great way to get in there if you're having overuse injury or you're trying to prevent injury, but you still want to train. And so maybe once or twice a week you're getting in the treadmill just to give your body a break from the impact of the ground, but you're still getting that mileage, you're still doing your training. So whether it be preventative or just ramping back up from an injury. And so it's basically simulating water, but we can be more objective and precise on our increases and what we're doing there. And basically you just wear shorts, like spandex shorts, and we zip you into this treadmill, and then it fills up with air, and that's how we can change that. It kind of feels like you're running or walking on a cloud. It's pretty cool, but then when you get out, the full impact of the ground is very heavy when you come back out of it. And then something we'd like to offer you guys, and when we're done, is feel free. We're going to have a sign-up sheet out front. If you feel like stuff we've talked about, you're not sure if it applies to you and you'd like to just do a screen with us, that's something that we can offer for you. We'll just get your contact information. We can email you, call you, and set up a screen to look at your flexibility, look at your strength, kind of look at those functional things. Like she said, you know, your single leg squat, your balance, just a quick screen to see if this applies to you and that you could either benefit from physical therapy, seeing a physician, or one of those video gait analysis.
I'm Emily. I'm a personal trainer here at the HealthPlex. My title is the Wellness Navigator. I run a program called MyFitRx specifically, but I'm also an individualized personal trainer as well. So just a little bit about the HealthPlex here. Who all is already a member of the HealthPlex? Everybody? Everybody, perfect. So you guys all know the facility. But we have plenty of group exercise classes as well that we offer outside of my specific program, specifically the trekking class. It's geared more towards runners, but it's at your own pace. If you're interested in taking it, it really pushes you to try to go up that next level, go up an incline, go down the incline, kind of see where you're at in that class, again, at your own pace. But I know that's one of our more popular running classes here as well. We have our indoor track if you're interested in just walking, running, rainy day outside, come inside, walk around our track. If you're not a fan of the treadmill, like they also said, we also offer some of that human performance testing, so that VO2 max and that lactate testing as well. That's also a specialized service. That's not something I personally do, but that's something you can schedule here in the HealthPlex as well. There are 10 other personal trainers. There's a lot of personal trainers in the facility as well that can help you with a lot of that strengthening that they also talked about with that gait. So strengthening those glutes for your stride. If you're looking for more of the osteoporosis side of it, that would be more probably MyFitRx, more specialized programming. And then talking more about MyFitRx here, we have an 8-week-long program that you could come into for individualized specialties here. So we have 10 different pathways. So most of you guys for running, walking would fall more under that functional fitness or the orthopedic. If you're coming in from a knee surgery, knee injury, hip injury, that functional pathway, you'd fall under if we just need to do some basic strengthening for that gait process. But if you think you fall under any other pathway, let me know, let your physician know, take a referral to them and be like, hey, I think this would be a good fit for me. Also, physical therapists can refer to the program as well. So if you go to them to get a gait analysis and they're like, hey, maybe you just need some basic strength training, you come to me instead. I just talked about the functional pathway here. So 8-week program structure. The first week, we're going to do your pre-assessment. Within that pre-assessment, that's going to be more geared towards walking, running, is going to be that balance. So standing on one leg, how is that hip strength going to work for you, or standing on that heel to toe stance here as well. So how centered is our gravity? How centered is that strength in our hips? We have a 6-minute walk test, kind of test your VO2 max and how many yards you can cover in 6 minutes. I'm also looking at your gait in that walk process. So if we're having a chat and I kind of am falling behind you a little bit, and I'm watching how you're walking in that process, seeing if you're kind of dipping to one side, seeing if that knee is caving in a little bit. And then we also do the functional movement test. So we do that squat test. So I'm looking at how in line your knees are, how in line those hips are, if we're keeping that tall chest as well, which all goes to how you're walking and how you're running as well. And then after that pre-assessment, I have kind of gone all over all of our numbers. I create your individualized workout plan. So then we'll go into your supervised session starting in that same week as your pre-assessment. And from there, you'll get 2 sessions with me per week. You get that individualized workout. It's not one-on-one time though. There's 35, 40 people within the program total. So anywhere from 1 to 6 people show up to a session time. But you still get that about like 5 minutes one-on-one every few minutes. I'm walking around, bouncing around to everybody, checking in, making sure everyone's doing everything correctly, checking your progress, checking your form. So it's not that one-on-one personal training that you would get if you were to jump to a normal personal trainer, but within this program, you still get that individualized workout 8-week structure. And then once we come to our end of our 8 weeks, we'll do a post-assessment. So we're going to run through all of those same measurements that we did in week 1. So we can see your progress on your balance test, your squat test, and your walk test. A few other tests in there, but these are the ones that pertain to walking and running. So we can kind of see assess your progress through those 8 weeks. Granted, 8 weeks isn't a super long period of time in a full fitness journey, but that's enough time to kind of see how much we have strengthened our glutes, our hip, and then see if that gait has improved a little bit as well. So again, if we strengthen that right hip, if that's the hip that was dipping, we can see that has gotten stronger over those 8 weeks. So if you have any questions.